All right. So again, those of you that are needing CEUs for social work or for LPC, there's my information. Sometimes you get asked for that. So that'll be on the slide and you will receive this. But let's go ahead and get started. There's our educational objectives for today. We're going to define dementia and talk about some of the different types of dementia. There's over 130 different kinds, so we're just going to touch on the ones that we see the most often. We're going to look at a list of symptoms for dementia. We're going to look at the most common, and there's about 30 that are pretty common, 35, 36 that we continue to see. Got a lot of people coming in real quick. Let me let everybody in. My co-host Jamie isn't with me today, so let me get everybody entered here. Then we're going to talk about, again, different types of dementia and some treatment options, what we can do. But one of the most common questions we get asked on a daily, there's not a day go by that we don't get asked two things. What's the difference between Alzheimer's and dementia, which we'll talk about that. And then what is normal aging and what is abnormal aging? The general public, most people think that memory loss is a part of getting older, and it's not. It is not a normal part of getting older, but there are some things that are a part of getting older. And so we're going to try to look at that and see what are some things that we should be concerned about in ourselves and in others, in our loved ones, and then what are some things that are just a normal part of aging. So there are some things that change. We know that things change, such as we're going to have some changes in our vision. We may have some changes in our hearing. We may have some changes in our strength, in our stamina. But those are a slow and usually a subtle decline. They shouldn't really change the way we function necessarily, though. So we're going to look at what is the difference then in a healthy older brain, and then a brain that may be having some issues that could be dementia. So these are some things that we see in an older healthy brain. So the communication's just a little bit slower. We may have more of those moments where we walk in the room and go, now, why did I come in here? Hold on a minute. This can also be due to stress. This can also be due to a year of a pandemic and isolation and those type things. So we can usually retrace our steps, though, and figure out why we came in the room. We may even start to see some atrophy. If for some reason we have to have an MRI or some type of a scan, there may be some atrophy that's there just from aging. We can have some inflammation. We may not be able to multitask like we used to be able to multitask when we were in our 20s or 30s, maybe even our 40s, where we could have a kid on our hip, we're talking on the phone, we're cooking dinner, and we're watching TV and keeping up with it. That's going to slow down. We may not multitask as well. That's all normal aging. That slower response to sensory stimulation, again, vision changes, hearing changes, even tactile type things change. But some things that stay and even get better, we become even more resourceful the older we get because of life experience. You know, we're wise. We call it getting wise. We're very resourceful because we have lived longer. Our comprehension is still there. Our general knowledge even improves, where that big umbrella of things that we know improves as time goes on. So our ability to perceive others' emotions and making better decisions improves, where we're reading somebody, we're reading their body language, we're reading their gestures. We're able to adapt to new challenges as tasks. We may not want to, but we can. So that's one of the big things I will tell folks. If you can learn how to use that whenever the phone updates, you can learn how to do it. You don't want to, but you can. That is normal aging. Somebody who has developed a type of dementia, there is no new learning. In fact, that phone eventually usually becomes a remote control, or they just don't know what it is at all. But a normal older brain, you can still learn new things. And then you've got all this reserve, this cognitive reserve. even when a part of the brain might be disrupted for some reason. And we'll look at some of those. So here's some more normal aging. Your recall may be a little bit slower, where you're looking at somebody, you know them, it's on the tip of your tongue, and it might not even come to you till the middle of the night, but it does come to you because it's still there. Your recall's a little bit slower. You may catch in yourself some memory slips, but you're catching it. You realize it, and you can give detail to it. I was at the store 2 days ago, and while I was in there, I was thinking, you're still able to give detail to a memory slip. That's normal aging. On that third bullet point, does not get lost in familiar places, but you may have to momentarily pause to remember the way. So I think we've probably all done this also. Where did I park my car? Wait a minute, I didn't even come in this door at Target. I came in the other door. That's why I can't find my car. So that is normal aging. You may just have to stop a minute to remember, where did I park the car? Or I drove to this place 6 months ago, just a minute. I've got to remember how to get back there, but we're not completely lost. We just talked about this one, able to operate common devices, even if unwilling to learn how to operate new devices. But you could if you wanted to. That's normal aging. Your social skills should not change. That is not a part of normal aging. Your social skills should stay the same. And again, sometimes we'll hear that. Somebody will say, oh, they're just doing that because they're getting older. That's why and they're making an excuse for maybe a lack of social skills, but we shouldn't lose our social skills. Normal aging, we keep our social skills. And then recent memory for important events, affairs, conversations, those type of things are not impaired as we age. Now, we may do something, another thing to keep in mind, where we started something, we got distracted and we didn't come back to it, but we remember later, I did start that list of whatever. We come back to it. It just takes us a little bit longer. Here's some more on normal aging, and then after this, we'll look at some abnormal aging. The person may be more concerned about alleged forgetfulness. The person, you, are more concerned about forgetfulness than your family members are. You seem to be more concerned about yourself, but nobody else is really mentioning it to you. That is normal aging because you're seeing some things in yourself. You may find yourself looking for words more often. Again, where you're saying, just a minute, hold on. It's on the tip of my tongue. I know what it is. Normal aging. Again, why did I walk in the room? Where did I put my keys? Where are my sunglasses? Where's the phone? Where's the remote? You know what you're looking for. That's normal aging. Let's see if there's any of these I haven't hit yet. Ability to reason and make sense out of information does not decline. You should still be able to be reasonable and rational. It doesn't mean that you are always reasonable or rational, but you have the ability to be reasonable and rational. So now let's look at abnormal aging. And I said earlier, abnormal aging, memory loss is not a normal part of aging. We used to say, you probably have heard this term, oh, they're just getting senile. Like that is a normal part of aging. It's not. It's not a normal part of aging. So this is these are the key words in that first bullet point. Forgetfulness that disrupts daily life. If there's an issue with yourself or with someone else and their forgetfulness, their memory issues are starting to disrupt daily life, that is not normal aging. Something's going on. And we'll talk about what it could be, because there are other things that it could be. We don't want to automatically just jump to it's dementia, because there are things that mimic dementia and there are things that have symptoms of dementia that aren't. So we'll go over those today. That third bullet point about getting lost in familiar territory, and it may take hours to eventually return home. Sometimes this is one of those first signs that families see. They've always driven to Brahms and back, and it took them 2 hours to get back this time, but they did get back. But they got lost going someplace that they've been 100 times. That is not normal aging. Becomes less able to operate common devices and unable to learn how to operate new, simple devices. So a device that maybe they learned, maybe we got a new TV last year and we got a new universal remote, and they've been able to use it and now they can't. Or a microwave, a microwave that maybe you've got to push and then they can't use it and you can't teach them how. They cannot follow the directions. That is not normal aging. They may start to withdraw socially and behave inappropriate in social situations, saying or doing things that they never would have done before. And then seeing that decline in memory for recent events, and then having a difficult time being able to have a conversation also. Now, like with normal aging, we're more concerned about it than anybody else is. Abnormal aging, typically family members or friends become more concerned about instances of memory loss than the person themselves because they don't realize they're having them. Sometimes they will, but most of the time, the family and friends get much more concerned than the person themselves because they aren't realizing that they're even having it. They start having frequent trouble, not occasional trouble, but frequent trouble with finding the word. You'll start hearing things like stuff and thing. You know that thing, the stuff. You know that stuff, that thing. The thing that writes. So they know what it does, but they don't know it's the pen. That thing for the TV, you know, and they're talking about the remote. Not being able to retrace steps, misplacing things more often, putting things in odd places, the keys in the freezer, the milk's in the cabinet. Now, again, if we do that every once in a great while, that's normal. But when you start seeing a pattern or it happens more and more often, or they firmly believe that the keys go in the freezer, forgetting how to do those familiar activities. And this can be things like activities of daily living, brushing teeth, shaving, combing hair. What order does this go in? You may see their mood and personality start to change, and then not being able to be reasonable or rational or decrease judgment, maybe writing checks, giving away money, stopping at a stop light, looking both ways and then going. And no matter how much you talk, they said, I stopped, but it was a light. That's abnormal aging. So again, keeping in mind that any dementia is not a normal part of aging. So what is the definition of dementia? When you think about dementia, typically whenever we say, whenever we're teaching classes or we've got students and we say something like, tell me everything that you know about dementia, we have 3 responses that are the most common. So I want you to kind of think through, if you were to start just listing everything that you know about dementia, typically what we hear is memory loss, they forget, and they can't remember. And those are all 3 the same thing, memory loss. And there's actually some dementias that can present with no memory loss, 2 in particular that present with a long list of other symptoms, but memory loss isn't one of them. There's about 35, 36 common symptoms to dementia. And dementia is just an umbrella term. That's all it is. Just like cancer is an umbrella term. If somebody were to say, my mother just got diagnosed with cancer, our first question would be, what kind of cancer? What type of cancer? Same thing with dementia. My mom has just been diagnosed with dementia. What kind of dementia? What type of dementia? So the word dementia is just that general umbrella term. And what it means is there are at least 2 problems with brain function. And typically it's two of these three that's on that second bullet point. Memory loss, typically, impaired judgment, impaired language. Now, there are many, many, many other brain functions, but we usually see two of the three of those. So the word dementia is not a specific disease. It's a collection of symptoms, and it can be caused by several different disorders. The most common of those is Alzheimer's disease. So Alzheimer's disease is the most common type of dementia. So if a person says, I've heard this said both ways, my dad has Alzheimer's disease, but he doesn't have dementia. That's not correct. Yes, he does. If he has Alzheimer's disease, he has the most common type of dementia. But they could say, my dad has dementia, but he doesn't have Alzheimer's disease. That's right, because he may have vascular dementia and not have Alzheimer's. He may have Parkinson's disease dementia, or frontotemporal dementia, or Lewy body dementia, or any of a slew of other different types of dementia. Then there's those that have a mixed or a dual diagnosis where they have both Alzheimer's and vascular, or frontotemporal and vascular, because they can have more than one at a time. All dementias are progressive. All dementias are terminal. It is not a normal part of aging, and it is not contagious. And I hate that I have to put that on there, but especially care partners of those that have dementia many times will honestly get to thinking, I've had people say to me, I think I've caught it. We can't catch it. You don't catch it. But sometimes just being around somebody with dementia, you may find yourself starting to do things like they do, but it is not contagious. This is just another, so that you can see, it's a visual showing you that umbrella. The umbrella term of dementia, and then the different types of dementia that falls under that umbrella. And again, over 130 different types. Two brain functions have to have an issue: the memory loss, the judgment, or the language. Usually, those are the ones that we see. So what are some other causes for memory loss and confusion? Last week on our 30-minute program that we do on Thursdays, I did a program on other brain disorders, and we talked about almost all of these. If that's something you're interested in, you can email me and I can send it to you, because we kind of did a deep dive into each one. And that video is on our James L. West YouTube page. Tomorrow, while I'm thinking of it, that 30-minute program is on working through caregiver guilt. So tomorrow on Thursday at 11 to 11:30, we'll do working through caregiver guilt. So other things that can cause memory loss. If a person is starting to have some memory loss, or they seem to be more confused than they normally are, today is Wednesday, and already this week I've had 2 calls about this. One about a family member, one about a friend. What do I do next? We're going to want to go to a primary care physician first, because there are some things that we can treat, and then that memory loss or that confusion will clear up. So sometimes you'll hear the term reversible dementia. I hate that term, because the word dementia, that word doesn't mean memory loss. But you'll hear reversible dementia. What that means is reversible memory loss, because there are some things that cause memory loss that you can treat and they get better. If they actually have a dementia, that isn't reversible. But if somebody has an infection, if somebody has become septic because of a severe infection and they are acting confused, that can be treated and then it clears up. Other health conditions, if you look there, anything that has to do with the cardiovascular system. So any type of a heart condition, diabetes, people who have sleep apnea that is not treated with a CPAP, or a thyroid disorder. When somebody has a thyroid disorder and they have lost or gained even as little as 5 pounds and their medication needs to be adjusted, sometimes that can cause some confusion, and it can even appear to be memory loss. It looks like memory loss, and all they need is their thyroid medication adjusted. Metabolic disorders, if somebody is malnourished, if they have a vitamin deficiency, we really talked a lot about this one last week. because a person can be overweight and be malnourished because of what they're eating, because they've got vitamin deficiencies. Then they can appear to have some memory loss. They can be very confused. We don't want to jump right to, oh, I bet that's dementia. Another thing is medication interactions. We talked about polypharmacy, and the percentage of, it's over 50%. In fact, I think it was 51, 52% of people who take 10 or more medications. Now, that does not have to be 10 prescription medications. Think about prescription medications, over-the-counter medications, and supplements. That falls in there. A lot of people take more than 10. But over 50% of people who take more than 10 medications of some type have confusion and memory loss because of the medication interacting with each other. That's important, that when we go to that doctor, that we list everything we take, even if it's a supplement, because sometimes folks will say, but it's all natural, it's herbal. It still needs to be listed on there. Lifestyle choices such as alcohol and drugs, smoking affects cardiovascular system. So the numbers right now on alcohol and prescription drug use are way, way up because of the isolation, because of the pandemic. I think the last numbers I saw in men, it was over 50%. In women, I think it was close to 40% use of alcohol. That's up. And a lot of times that's being mixed with prescription medications for depression or anxiety. And then they start to have some confusion and some memory loss. That's all reversible as long as they change the lifestyle choices. Other things that can have some memory loss, some confusion, people who have ALS or MS, multiple sclerosis, Lyme disease. There's actually, they call it Lyme disease dementia, but it's reversible as they treat the Lyme disease. People who have epilepsy, who have seizures, can start to have some confusion and some memory loss. And then specifically, and we're going to talk a little more about depression, anxiety, and stress. There's actually a link now between lifelong depression, major depressive disorder, and vascular dementia. But somebody who is in a really severe or a deep depressive, having a depressive episode, can have memory loss. Depression is treatable. About 90% of the time, depression can be reversed. And then that other 10%, the symptoms of depression can be helped tremendously. So that's one of those, again, getting to the doctor, getting that diagnosis and taking care of this instead of wondering what's going on. And we've got a lot of depression, anxiety, and stress right now. So this slide has a tremendous amount of information on it, and I put it all on one slide on purpose so that you could look at it and see. And again, I know that may be hard to see. You are going to get copies of these slides. These are the signs and symptoms of dementia, and this isn't all of them. This is the majority of them. So again, whenever I asked you earlier, what's everything that you know about dementia? And you may have only been able to think of 1, 2, maybe 3, unless you're living with somebody who has it, then you probably recognize all of these. But so many times when we start going over the signs and symptoms of dementia, we don't realize I had no idea that was part of dementia. I thought that was part of them getting older, when it was not a normal part of getting older. This was it rearing its head. If you do have a loved one with dementia or have had a loved one with dementia, you may even think back as you look at this list, and you may see things on this list that you were seeing 5 years before their diagnosis, 10 years before their diagnosis. We know, especially with Alzheimer's disease, the most common type of dementia, that plaque begins to grow on their brain. They believe in some people up to 20 years before they actually get a diagnosis. But you may have been starting to see some of these things and may have been putting it off to something else. Or again, you may have been saying, oh, I think they're just getting older. So the first one that is listed is memory loss, even though, again, there are 2 types of dementia that present with no memory loss or can present with no memory loss, and we will talk about those. It typically starts with immediate memory and then short-term and then long-term. Some people go the entire course of the disease and will keep that long-term memory. But immediate memory would be an immediate recall. That's why some of those first few assessments they'll do will be, I'm going to give you the name of 5 items, and I'm going to ask you for those 5 items again in 2 minutes to see if they have immediate recall. You may also hear, if you set in with assessments when your loved one's going to the doctor, or if you have this assessment yourself, where they may ask you, name as many animals as you can in 2 minutes, where it's that fast recall. Repeating questions, asking that same question over and over, especially if it is about an appointment or a time. Today's the day we go to church, right? Is this the day we're going to church? Is today the day we're going to church? Something that has to do with the schedule. It might even be something like a dinner. Is it time for dinner? Is it time for dinner? We've already had dinner. Is it time for Wheel of Fortune to come on? That type thing, where it has to do with they're trying to figure out the sequence of their day. Some other things that you may see that you may not even realize have to do with dementia is destroying property, taking things apart, loss of inhibition. Rather than going and turning down the thermostat, they just start taking their clothes off. Because if you think about it, that's reasonable and rational behavior. I've got this tag that's bothering me right here. I would say, hey, could you cut that tag out for me? But somebody with dementia might just get rid of the tag by taking the clothes off, because they're not having that reasonable and rational. That's all up here in the frontal part of the brain. And as the brain begins to atrophy with dementia, they will lose the ability to be reasonable and rational. They may appear to be depressed, anxious, or worried, and they don't know why. And you're asking them, what's going on? Just tell me. And they can't tell you. They don't know. They can't put the words to it. Some people do become aggressive. Not everybody becomes aggressive, but at different times during the disease, you may see your loved one become aggressive, or you may see your residents become aggressive. Now let's think about why that happens. You're asking me to do something that, first of all, I don't even need to do. I already know how to do, and you're trying to do it for me. And they don't have the ability to say to you, I don't need your help with, but I can pull up a fist, or I can spit, or I can kick, or I can pinch, or I can say a bad word, even if I've never said bad words before. As those language centers change in the brain, we've got language on the left and language on the right. Our regular everyday language is over here on the left language. And we know that in people who have dementia, that they lose that left side first. That left side language goes first. The right side language stays. And here's how you remember that: right rhythm, right rhythmic language. And right retains rhythm. What's rhythmic language? Sing song, songs, poetry. Prayer falls under rhythmic language. Our Father who art in heaven, hallowed be, has a rhythm. But unfortunately, there's other words that fall under rhythmic language. Curse words, racial slurs. All of those words that we were told, I better not hear you say that word again, when we were little. Because we didn't store it over here on the left with our regular day-to-day language, because we were told don't use that word. We store it over here on the right, special words, and they stay. So when they get to where you're trying to get me to do something I don't want to do, you're trying to assist me with something that I don't need your help with, you may hear words that you have never heard before. And that's where we have to look through the words to the feelings and the emotions. What they're trying to say is, I don't understand. I'm not happy. And we can't take those personally, even though it feels very personal when they're looking us in the face and saying those words. All of their behaviors have a meaning. All of their behaviors are a type of communication. You may see somebody start to be tearful or cry more often, and again, they can't tell you why. Earlier in the disease, folks will talk about being a burden, or I don't want to, you're too busy, I don't want to call on the kids to help, I'm just a burden, that type thing. Having those problems with bathing, dressing, grooming, anything that has sequence, anything that has order, you may start seeing issues with that. Changes in appetite, where they either gorge because they're not remembering that they just ate 30 minutes ago, or they're not eating because they think they just ate. Changes in gait, where they trip or fall. They may start walking kind of with their hands out to the side. Think about how a toddler walks, where they kind of pooch their belly out and they'll have their hands out. You'll kind of see, a lot of times we'll call that a dementia shuffle. They're not picking their feet up all the way. Hallucinations and delusions. They may be seeing things that aren't there, or they may be seeing things. I have used the story many times of the gentleman who had white lights on his Christmas tree, and they were running lights. So on the floor, he was yelling, white mice, white mice. And it was white lights. And it's just his perception of what he was seeing. Inappropriate sexual behavior, and then following you everywhere or wanting to be right beside you. Because if you're a primary care partner of somebody with dementia, you get to play a dual role. You're the good guy. Don't get out of my sight. What you do must be right. If you're there, I must be there also. But you're also the bad guy, because you're the one making me take my medicine, and you're the one making me get in the bathtub, and you're the one. So you start playing that dual role of good guy, bad guy. So we're just going to talk about the 5 most common types of dementia just briefly. We've done deep dives into each of these recently. There's an entire program on our YouTube channel about each of these top 5 types of dementia. So Alzheimer's disease, as I said earlier, is the most common type of dementia. It causes the brain to shrink. It causes the cells to die. About 70% of all dementias is Alzheimer's. You can find statistics from 60 to 80. It is continuous. They will plateau and then they'll progress. They'll plateau and then they'll progress. Now that's with all the dementias. There'll be a plateau and a progression. Sometimes it's just a natural progression. Sometimes things can throw them into a progression. Really, really bad news can throw somebody into a progression. A UTI can throw somebody into a progression. Getting very, very sick, having the flu, having COVID, being separated from loved ones for a year. We saw some people that just went into a progression of the disease. General anesthesia is the #1 accelerator of dementia. If they have to have general anesthesia where they're intubated, not twilight, not a local, but general anesthesia where they're intubated. If they're at the mild level, they'll come out of that operation at the moderate. If they're moderate, they'll come out severe. And an awful lot of people who are severe don't come out from the surgery, or they have about 3 months afterwards. We now know in people with Alzheimer's disease, that plaque that's on the brain, because they're actually growing plaque on the brain with Alzheimer's disease, something in general anesthesia, it's like throwing gas on a fire. We didn't even know that several years ago, but now we know that. So that's where we want to avoid general anesthesia if we can, or make sure we talk to that anesthesiologist and see if there's a different type of anesthesia that can be used. So again, caused by plaques and tangles on the brain, it is now, Alzheimer's disease is now the 4th leading cause of death in people over the age of 65 in the United States. Of the top 10 reasons that people in the United States over the age of 65 die, it's the least funded. Let me just throw that in there. The least funded of the top 10 reasons. Vascular dementia, 2nd most common type, and it's exactly what it sounds like. It has to do with the cardiovascular system. Most of the time it is caused by TIAs, and that's those little mini pinpoint strokes in the brain. They can actually be, most of them can be seen on an MRI. It's the one dementia that can have a sudden onset. The others come on gradually, even though sometimes it feels like, they went in, they had that surgery, and they woke up with dementia. I've heard that many, many times. And then I'll show them that list of all the different symptoms, and they go, oh, I thought that was just part of getting older. I didn't realize, yes, they were doing that before the surgery. And then that surgery just accelerated it. So TIAs, but there are things that cause TIAs. What's that? High blood pressure, high cholesterol, diabetes, any type of heart issue. People who smoke are at a very, very high risk of having TIAs, which puts them at a very high risk of having vascular dementia. Typically with vascular dementia, their personality and their emotions remain intact. I had a resident, I'm looking at her picture right now, I've got her picture right in front of my desk. All the way to the end of her life, she knew my name, she knew her children's name, she knew that type of thing she knew, but she would confuse TV and reality. If she watched, she loved NCIS, CSI, all of those shows. She thought they were real. People were in her room, people had guns, they were shooting up her room. That's what her vascular dementia looked like, but she knew my name, which was a little bit different with some of the other dementias. So her personality remained intact. Their judgment isn't usually affected until later in the disease with vascular dementia. And with vascular, it depends on where in the brain they have the stroke or where in the brain there's damage. Lewy body dementia is one of the two that I mentioned that can present with no memory loss. As a matter of fact, many times it presents as Parkinson's, and they can even get misdiagnosed as Parkinson's. Now, what makes that even more difficult is you can have Lewy body and have Parkinson's. You can have Parkinson's and have Lewy body. The way that they word it, whichever disease you had first is what's, so if it's Parkinson's with Lewy body, you had Parkinson's first, vice versa. And what happens is these structures start to grow on the brain that are called Lewy bodies. And Mr. Lewy actually worked with Mr. Alzheimer in his lab way, way, way back there. So it was just a gentleman whose last name was Lewy, a doctor. And they start to grow on the brain. So they're called Lewy bodies. This usually takes place in a person's 60s. More men have it than women. And it typically starts with problems with mobility and falls and hallucinations. And if you know anything at all about Parkinson's, that sounds a whole lot like Parkinson's. And so again, many times they will get misdiagnosed. One of the most difficult things about Lewy body dementia is that if you treat the Parkinson-like problems with the falls and the gait, it makes the hallucinations worse. And if you treat the hallucinations, it makes the falls and the mobility worse. So it's very, very difficult to treat. Frontotemporal dementia. And frontotemporal dementia is also an umbrella because underneath frontotemporal dementia, there are different types of FTD or frontotemporal dementias. And again, we've got an entire program just on FTD. Personality changes is usually what we see first with somebody who has FTD. And what's happening is they're having degeneration either in this frontal lobe or this temporal lobe or both. We usually see it in younger folks also between 30 and 65. About 50% of the time, this is a family history, where in other types of dementias, it's closer to around 30% of the time. It's 4 times more common in men, frontotemporal dementia is. And you start seeing judgment and social behaviors affected first, becoming very socially inappropriate, saying and doing things at church, at a ball game, in Walmart, out in public. They may take things, they may expose themselves, they may say things, again, very inappropriate that they never, ever would have said. They'll have a flat affect, and it presents as an emotional or a mental disorder, and it doesn't present with memory loss. So many times these folks will get misdiagnosed as bipolar, schizophrenic, major depressive disorder, all types of other things when it's actually frontotemporal dementia. And then the fifth one that we're going to just briefly talk about is Parkinson's disease dementia. And so this is when somebody does have Parkinson's disease. They've already been diagnosed with Parkinson's disease, and then they develop dementia. About 50 to 80% of those with Parkinson's will eventually develop Parkinson's disease dementia. I know that's a pretty big span, but that's some big numbers there. And they'll start to have a decline in thinking, reasoning, problem solving, enough to impact their daily life on top of the Parkinson's. So what are some risk factors for dementia? The number one risk factor is age. Typically, we will see folks get diagnosed around that age of 80. But with that being said, when our day program was open, we had someone in our day program who was 47 years old. I personally know somebody in Fort Worth who's 32 years old with Alzheimer's disease. So dementia can be, and it is not just an old person's disease. That's another thing that where we have so many people who think, oh, memory loss is just part of getting older and dementia is just an old person's disease. No, it isn't. It's called early onset if they're diagnosed before the age of 65. It's late onset if they're diagnosed after 65. We talked a little bit about genetics and family history, smoking, obesity, a sedentary lifestyle, alcohol use, talked about that, a buildup of plaque in the arteries, that's part of that cardiovascular system. Major depressive disorder, in the very next slide, we're going to talk about the link between depression and dementia. We've mentioned cholesterol. They have now found this high amino acid factor in Alzheimer's and vascular disease. Diabetes, somebody who is antisocial or who just does not get out or socialize very much at all, at a higher risk for dementia, not engaging in brain activities. And then anybody who's been diagnosed with mild cognitive impairment, typically 40% of those people within 3 years that will be diagnosed as dementia, some type of dementia. So again, we have a whole program on depression and dementia. We did one called Depression versus Dementia. How can you tell the difference? What are the signs? What are the symptoms? And how do I get treated for that? This picture is very, very powerful. If you look at the difference there, when somebody has a tremendous amount of anxiety or they have something more than situational depression, we all have situational depression. We go through a divorce, somebody dies, we lose a job, we have a blizzard and our pipes bust in our house and we lose a lot of stuff. That's situational depression, and it's going to pass because the situation's going to change. That's not what we're talking about here. We're talking about sometimes lifelong major depressive disorder. It changes our brain chemistry. And what they have found, what research has found, is that it actually changes the hippocampus, and the hippocampus is what is the memory center of our brain. So that's where they have finally tied that link between depression and dementia. Then another area that is damaged by depression is that conflict resolution center, prefrontal cortex, and that has to do with planning, executive function. So there is now a link between depression and dementia. So how do we get a diagnosis of dementia? Like I said earlier, we're going to start at our primary care physician. We want to get in there. We want to have complete blood work done. If this is something other than a dementia, if this is a thyroid disorder, if this is a vitamin deficiency, we can treat that. We want to get on top of it. So the sooner we get there, the better. Good primary care physician is going to do an interview of the patient, and they're going to do an interview of that care partner. If you're seeing this in a loved one, my first suggestion is to get a notebook and keep track, date and time and behavior, date and time and behavior. Can you see a pattern? Take that with you to the doctor, because you all know we get in the doctor's office, they've got about 7 minutes. And then later this evening, I should have mentioned that while I was there. Keep a notebook, carry it in your purse, carry it in your bag. They're also going to take a thorough medical and family history. They should look at every medication. So that's where we also want to make sure we always have that list of all medications, over the counter and supplements. There should be a physical exam. There should be a mental status exam. They do one in a primary care office called an MMSE, a mini mental status exam, state exam. Lab work should be done, and they might order imaging tests. Typically, though, you'll get referred then, if it isn't something that can be treated there at the primary care, to a neurologist or a geriatrician, and they then many times will either order more blood work, But this is where you typically will get a scan, some type of a scan. They may order an MRI, a CT, a PET scan. They may do an EEG. Sometimes they will do a lumbar puncture to test for proteins in spinal fluid to rule out other things or to show something like Parkinson's. I was on a program last week where they were showing that now in those lumbar punctures, they're starting to be able to see that they are thinking they may be able to even diagnose Alzheimer's disease. We're right on the verge of an awful lot of breakthroughs, but they start to rule out. You can also see, and the neurologist may send you to a neuropsychologist where they will do some neuropsych testing. Sometimes this is those 4 to 6 hour testing where they're going to test orientation, memory, attention, verbal and written commands, and other cognitive abilities. So right here, let me also throw in, if you're seeing some things in yourself, another reason to go is to get a baseline. Go in and get that baseline. So if you have to go back in 2 years, you can look back and have a baseline for you or your loved one. So we want to go and get that early and right diagnosis so that we can rule out other reversible memory issues. But another reason we want to go is because we may be able to get into a drug trial. We also want to make sure that we have the opportunity to participate in decisions about our own care, about our transportation, about our living options in the future. We want to take care of financial and legal matters if we haven't already. Of course, we always encourage everybody who's over the age of 18 to make sure you already have your stuff in order, which most people do not, because we tend to think that nothing's ever going to happen to us. But I've sat across the table from way too many families going, we never talked about it. I don't know what their wishes are. I'm not sure what to do at this point. And if we wait until they are far into the disease to even get a diagnosis, or if we ourselves wait, then we don't even have a say in our care. So the question then comes up, why get tested if there's not a cure? One of those calls I had this week asked me this. Why would I go find out about something if there's not a cure? And my first thing was, what if it isn't this? What if it is something else? And then even if it is this, don't you want to say and what the rest of your life looks like to be able to plan? Family members also, this is where you can start to educate yourself. And I've recognized many of you on this call, and I think you'd agree that the more you know about it, the better you're going to be, whether it's your own journey or somebody else's journey. Whether we work in the field or we're a care partner to a loved one, the more information we have about it as they turn those corners in the disease, if we at least know about it and it doesn't completely come as a shock or a surprise. Making changes in lifestyle choices that can help symptoms of the disease and slow the progression, because there's things that we can do. We can make those diet changes. We can make sure we're getting exercise to pump oxygenated blood up to the brain. Why wouldn't we do that every day? And then we start to focus on what's important. So when we get asked, is there a treatment for dementia? There's not a cure. There's no cure for any of the dementias right now. We hope there will be. Our motto here is, until there's a cure, we're here to care. We would love to change the name of our building. But right now, there's not a cure for dementia. All of the medicines, even the ones that are called memory meds, those are treating symptoms. And they're used to improve their mental functions, their mood, and their behavior. Another thing that everybody who has dementia, we focus on palliative care. And palliative care is comfort care. Making sure that we have quality of life, because we have a terminal illness. Somebody has dementia, that's a terminal illness. That doesn't mean it's time to go on hospice right away. But keep in mind also, hospice doesn't mean that they're dying tomorrow. Hospice means we think they have 6 months or less. And so many folks are afraid of that word hospice. But there's palliative care, comfort care, quality of life care, where we focus on the body and the mind and the spirit. We can get support and we can get counseling for the person who has dementia as well as the care partner. Earlier in the disease, some people who have got a diagnosis of dementia will benefit from that. I'll have people sometimes ask for counseling for a loved one who is well into the disease, and who needs the counseling and the support is the care partners. So this is some different types of psychotherapy, talk therapy, and counseling. Cognitive behavior therapy helps a lot with people who are care partners of those with dementia. It helps us kind of reframe and stay in the present, being mindful. We use this a lot also with people who are depressed, and depression and dementia tend to go hand in hand for care partners of those who have dementia, and for a person who has dementia, we'll see a lot of depression. Interpersonal therapy is where we focus on the client and the relationship with a symptomatic as well as symptomatic recovery, and it's usually 12 to 16 weeks. Problem-solving therapy is designed to help manage negative, stressful events in life, focusing on day-to-day life. And then pastoral counseling also. And so many times we forget about our ministers, our rabbis, our priests. Many of them, they've been to seminary. They were trained on how to provide therapy services. Because what you're going through as a care partner of somebody with dementia is grief. We're living in this state of ambiguous grief. Ambiguous grief. We're grieving the living. People who haven't dealt with dementia don't understand that so many times, but we're actually grieving somebody who is alive. And so ministers can help with that. They use psychology, and then they use religious traditions in their counseling services. So please don't forget about that part of your support team as you're building a support team. Then there are different types of medications, and there are many more than this. These are the ones we see the most often. Not everybody can take all of these, just like if you have high blood pressure, sometimes they have to try several different ones, or an antidepressant, they may have to put two together or try a different one. But these are some of the most common ones that we see. You'll see the Aricept and the Exelon and the Namenda. Those are the three that you hear an awful lot to treat confusion. Some people, they will use an antipsychotic because they can be used for mood disorders, irritability, anxiety. But people will hear that term antipsychotic, or they'll just Google it and read the first thing that comes up and they're afraid of it. But you have to look at all of the different things that it treats. An antidepressant, because antidepressants, many times there's antidepressants, like Remeron's an antidepressant, but it's also an appetite stimulant, because there comes a time in the disease where they're going to stop eating. That part of the brain that says to eat, they're going to stop eating. Now, unfortunately, at some point, they're going to stop metabolizing that food, and there's nothing that we can do. Even if they do eat, they won't metabolize it. It's part of dementia, because that part of the brain isn't working anymore. But if they're just not eating, we can use an appetite stimulant that happens to also be an antidepressant. You can also see here there are medications to treat anxiety, restlessness. There's mood stabilizers. So there are some different, but look at what each of those are. Those are treating symptoms. Another way we treat dementia is by using different types of therapy. And these are so wonderful. They will go in and out of physical therapy, occupational therapy, speech therapy throughout the course of the disease. And we here at the West Center are big, big proponents of music therapy because it enhances their quality of life. So why they go in and out of these therapies? Therapists, physical therapy, occupational therapy, speech therapy are taught, they know how to tap into muscle memory. They know how to get, and especially those that are trained specific to memory care. They know how to tap into muscle memory that they have been using their whole life. So with physical therapy, that procedural memory and that muscle memory will help with a reduction in falls. So think about it. We haven't always been walking. So as this disease progresses, they eventually will get to the point that they're not walking, because we have not always been walking. So there is a time, just like when we were learning to walk, we had a lot of falls. When they're at the point that they're about to stop walking, we have a lot of falls because of what's going on in the brain. So physical therapy can help a tremendous amount. a task, being able to sit to stand, transfer, getting out of bed, those type of things. Occupational therapy is another one that they will go in and out of. It helps with their activities of daily living, being able to feed themselves, brush their own teeth, having strength, having endurance. And I've got on there, an occupational therapist might also advise on how to adapt your home. So if your loved one's still at home, they can come into the home and help you make your home safe. And then there's speech therapy. So a lot of folks get to go in speech. What does that have? Well, part of what speech therapy does also is swallowing. Again, one of the things that happens with dementia, eventually the flap in the throat that says, hey, that's air, that's water, that's food, it doesn't work anymore because it's controlled by the brain. So swallowing becomes an issue. And that's why they will have aspiration pneumonia, because it will go right straight into the lungs. So speech therapy comes in and they stimulate that cognitive ability. They help compensate for deficits. And then music therapy, again, you heard me say the right side of the brain has the rhythm and the right rhythmic stays. So keeping a beat. There's a beautiful video on YouTube about a woman and she's just sitting and they said she was hitting, and she wasn't hitting, she was rocking, she was self-soothing, she was keeping a beat is what she was doing. If you put that to a song or music, she was being able to express herself. Other interventions, and this is for our loved one who has dementia, or if we work in a community with dementia, we want to make sure to educate ourselves as much as we can and continue to learn as much as we can. Changing an environment if we're starting to have some behaviors, redirection, the number one thing, food, and more food, especially the sweeter, the better. Ice cream is God's gift to dementia. Music, their music, animals, and children are the four best distractions. I also put on here some interventions for stress and for depression for ourselves as healthcare workers or as care partners of those with dementia, or for our loved one with dementia. And the number one thing that you can do is exercise, because again, you're getting that oxygenated blood up to the brain. Keeping that in mind that when we have a loved one that has dementia, it's not a sprint, it's a marathon. This is going to take a long time. This is not a fast moving disease. Depending on how old they are when they're first diagnosed, we could be anywhere from 5 to 20 years. Most people kind of right in that 10-year. So making sure that we are doing some interventions for ourselves also. So these are some ways to help somebody who is stressed or depressed, making sure that we're offering them that support, never, ever ignoring signs or comments about suicide. The suicide rates last year were very, very high. A very high number of healthcare workers committing suicide last year because not asking for help, but trying to fix and help everybody else. Making sure that people have transportation if they're going to appointments, reminding them time and treatment that depression will and does lift. And then how do you help somebody who has dementia? First of all, you want to educate yourself. One of the best ways you can help somebody with dementia is by understanding the disease. There's a reason why in my office, everywhere I've ever worked, I have this sign that says, the dementia patient is not giving you a hard time. The dementia patient is having a hard time, because we have to remember that. And then focusing on their quality of life, staying focused on them, being flexible, going to their world, not trying to bring them to our world, and then taking care of ourselves. So some places where you can actually go for help, and we're right at time, and this is the last slide. We're on there. The Alzheimer's Association is on there, Dementia Friendly Fort Worth, the Central Texas Area Agency on Aging, and I've put some other resources on there. So again, you will get a copy of this presentation, and you'll get a copy of the slides. We are right at time. If anybody has any questions or comments. Thank you so much. I appreciate that. We appreciate y'all being on here. And again, we've got our support group today at 1 o'clock. We've got a support group Fridays at 11 o'clock. We've got a monthly support group that's called the Second Saturday Support, and that is specific to grief, loss, and bereavement. If you want information on any of these, please shoot me an email. My information's on this slide. Most of you have it anyway. So thanks so much. We'll see y'all later.